Hello, my name is Dr. Jill Einstein, and I'm the Senior Director of Physician Engagement for the MAVEN Project. Thank you all for joining us today, and thanks to our friends at Cherokee Health Systems in Tennessee for requesting today's session, Provider Burnout and Resilience with Dr. Tom Norris. And I'd love to tell you a little bit about Dr. Norris. He's a professor and chair emeritus of the University of Washington Department of Family Medicine. He spent 2 years as a Navy family physician prior to 10 years of full spectrum rural practice in a small town in Montana. He transitioned to academic practice, spending 5 years as the family medicine residency program director at Tacoma Family Medicine, followed by 23 years at the University of Washington School of Medicine in Seattle. At UW Medicine, he served in a number of roles, including Vice Dean for Academic Affairs and Professor and Chair of the Department of Family Medicine. Throughout his career, he has been clinically active with a focus on rural, underserved, and geriatric patients. He's also been very active in teaching, especially continuing medical education. Dr. Norris, it's a pleasure to have you here today, and I'm going to go ahead and turn it over to you.
Thanks, Jill, and good morning to those of you who are still on the morning side of the time zones. I'm on the West Coast, so it's still morning, and good afternoon to those of you in Tennessee and other places. I really appreciate the opportunity to talk with you this morning about a topic that's very, very important, and it's really impacting medicine a lot right now. So let's dive in and get started. A couple of disclosures to begin with. I really don't have any financial interest in any of the things that we're talking about, and nothing to disclose from the financial side. Learning objectives. At the end of today's talk, I hope you recognize the nature and scope of provider burnout. I hope you can recognize it in colleagues and in yourself. And I hope that you can work with your organization to implement some strategies to burnout, as well as to teach things that they burn out in themselves. I'm sure all of you have had days like this. The patient looking at the provider and saying, "I feel the way you look." I'm sure you've had days of this nature. What is burnout? Well, burnout, if you look in the dictionary, is exhaustion of physical or emotional strength or motivation as a result of prolonged stress and frustration. It's something that we as healthcare providers run into on an ongoing basis. And it's a real problem for us. And the problem has been increasing. The problem built steadily prior to the COVID pandemic. And it has worsened during the pandemic and continues to be present even after the end of the pandemic. This is a really important slide. It comes from some work by Tate Shanafelt and is published in the Mayo Clinic Proceedings. And it lays out in pretty graphic terms the impact that burnout has on an individual and on the organization where they work. Let's look a minute at the personal side of burnout. It can end up with broken relationships. Divorces are common among burned out healthcare providers. Oftentimes, it drives people into alcohol or substance abuse. It leads to depression, and it leads to suicide uncommonly frequently, as we'll see in just a minute. On the professional side, the quality of care goes down. The medical errors increase, patient satisfaction goes down, productivity goes down, and provider turnover goes up. So it's a bad thing for an individual and for the place where they work. A few comments about suicide. We lose about 400 physicians per year, equal to about 2 medical school classes, to suicide. There are not good numbers published on physician assistants or nurse practitioners, but I anticipate that they're quite high too. Physicians are twice as likely to kill themselves as non-physicians. Female physicians are 3 times more likely to kill themselves than their male counterparts. And the risks start early. We see studies showing increases in suicidal ideation in 4th-year medical students. Why? Well, burnout is one of the big reasons for provider suicide. It's frequently seen in association with untreated or inadequately treated depression. It frequently has substance abuse as a partner, and broken relationships are often playing a role. Well, why does clinician burnout matter? What difference does it make? Why don't we just ignore it and get on with life? Well, it matters, and it matters to the individual and to the place where they work. What's the impact of the burnout? Well, as I showed you on Shanafelt's slide earlier, there are substantial impacts. It has impacts on the provider, it has impacts on the provider's patients, and it has impacts on the organization where the provider works. It can hurt clinical outcomes, and there is a lot of data to back this up. It can hurt the patient's perception of their care. And lawsuits are more common against burned out healthcare providers than people who don't have burnout. It can drive up an organization's recruitment and retention costs because of the turnover that it promotes. It damages productivity, and the damage in productivity and the increase in costs increases operating costs for the organizations. Most federally qualified health centers don't have a lot of margin right now, and a large number are running in the red. And having more burnout going on in the organization makes that situation worse. It makes the likelihood of incivility, of grumpy interactions with colleagues and with staff more likely. It leads to malpractice litigation. It often leads the person who's experiencing it to block change or improvement initiatives in their organization. And it often makes the provider less compassionate and less empathetic to their patients' needs. There's a lot of literature to support the increase in medical errors, the increase in medical malpractice, the decrease in patient compliance because of the sense that their provider just doesn't get them, and the decrease in patient satisfaction. The data's out there. This isn't just somebody's idea of it. There is solid data to support the fact that burnout really does matter. Clinician leaders are especially vulnerable to burnout because not only are they dealing with the stresses from their practice, but they're dealing with the stresses from their management roles in the organization. They're more vulnerable to it, and the impact of burnout in provider leaders is more than just the impact in a provider. We've been talking about the impact in a provider, but if you put somebody in a leadership role and add burnout to it, it's a significant problem. My friend Bruder Stapleton, who was chair of pediatrics at the University of Washington, wrote, "As leaders experience emotional exhaustion and depersonalization, it seems likely that the team members they supervise will be adversely affected. Indeed, a leader's own level of burnout has been shown to adversely influence faculty burnout and professional satisfaction in Shanafelt's studies. This study found that 10% of the perceived variation in leaders' behaviors, including offering encouragement and treating others with respect and recognizing accomplishments, was associated with leader burnout." Leader burnout is a bigger deal than just provider burnout, and provider burnout in and of itself is a big deal. So if you're seeing this in your leaders, you really need to address it. So how do you diagnose it? What are the symptoms that one sees of someone who's burning out? Well, let's spend a few minutes looking at what's there. The first part is depersonalization of the patient. It's no longer the unfortunate lady and who I'm seeing who's having serious problems that are really impacting her life. It's the lady in the blue dress in room 3. Depersonalization, no longer seeing your patients as people and as folks who have problems that they need help with. In the individual, it's emotional exhaustion. They seem flat or depressed all of the time. They don't seem to be able to smile or laugh or react appropriately to interactions with others. And it's a belief that whatever you're doing just doesn't make any difference. One of the reasons that most of us are involved in healthcare is the opportunity to make a positive difference in the world. And people who are burning out or who are burned out lose that belief that they can make a difference. Maslach is a psychologist who came up with a way of testing for burnout. It's called the Maslach Burnout Inventory, or the MBI. And in this, they look at three different dimensions of burnout: the emotional exhaustion, the sense of being drained while you work with other people, and the dread that accompanies the thoughts of going to work, the cynicism, the dimension of depersonalization that I just mentioned, withdrawal, compassion fatigue, and the ineffectiveness or lack of efficacy, the loss of desire to accomplish great goals and make the world a better place. So the symptoms that you see: creeping cynicism, lack of passion, depersonalization, physical and emotional exhaustion, oftentimes headaches, inability to concentrate, depression, irritability, chronic complaining, inappropriate anger, insomnia, substance or alcohol abuse, and suicidal thoughts and behaviors. These are significant symptoms, and if you see them in yourself or see them in your colleagues or see them in your provider leadership, they are warning signs that you need to try to do something about them. Well, why are providers so burned out anyway? What's going on that makes providers in healthcare more likely to be burned out than people who are doing interactive work in other disciplines? This is really a useful slide, again, from Shanafelt's work. If you look at the very middle of the slide, the fact that we're doing what we do is because our work gives us meaning. And on the positive slide, on the positive side, on the engagement side, it gives us vigor, it gives us dedication, it gives us absorption. But on the burned out side, it gives us exhaustion and cynicism and inefficiency. So what are the pieces that play a role? And they're the colored blocks in the center. Workload and job demands can push people to one side or the other. Lack of control or flexibility, or increased control or flexibility, can push people to one side or the other. Imbalance between work and other pieces of life can push people to one side or the other. Social support in your work community or in the rest of your community can push people. Organizational culture and values can push people to one side or the other. One of the reasons people tend to work with the underserved in federally qualified health centers is because of the organizational culture and values. And it's one of the things that tends to push people towards the more optimal side, but doesn't work very well if somebody's highly cynical. And efficiency in the job area is something that pushes us towards the optimal side if it's working, or towards the less optimal side if it's not. Really useful slide in terms of understanding what really makes burnout happen. So let's look at some of the specific work factors, and there are a lot of studies that have been done looking at this. This is from the Physician Executive Journal from the American Association for Physician Leadership. And paperwork or electronic work with increased administrative demands is a major player. And if you think about the vulnerability of your provider leadership, the administrative demands can certainly play a role. Too many hours at work. Many of our organizations don't have full staffing. They're recruiting all the time. And the people who are there are being asked to pitch in extra hours. On-call schedules and expectations, concern about lawsuits, concern about insurance companies requiring a lot of extra work on the part of the provider, conflict or disagreement, increased complexity of care. Work your way down the list and you will see the work factors that tend to contribute to provider burnout. Jill, I'm going to pause for a minute. Do you have any particular questions that are showing up in the chat?
Not right now.
Okay, we'll move right on then. Jill, I'm not able to change slides. There we go. So number 1 is paperwork. Number 2 and 3 are too many hours on work or call. So which providers are most likely to be burned out? Well, if you look at the studies, again, it's people with frontline contact with patients. Among physicians, and there isn't good data for the advanced practice providers like physician assistants or nurse practitioners. But if you look among physicians, emergency doctors are at the top of the list, followed by other primary care providers. People in OBGYN, family medicine, internal medicine are highly vulnerable. For some reason, perhaps to do with the workloads at home coupled with the workloads at work, female providers are more likely to see burnout than male providers. This study was part of a trend that looked at where things were in 2013 and where things were 3 years or 4 years later in 2017. And the percentage of people burned out, the percentage of physicians burned out had increased from 40% to 51% between 2013 and 2017. And the percentage of female providers had increased from 45 to 55%, very significant increases. So what can we do to prevent or treat it? We talked about how you diagnose, we talked about what it is, we talked about how you diagnose it. So what can you do to prevent or treat burnout? Well, there are things that an individual can do and things that their organization can do. And hopefully, if these things are done, you end up with an engaged it is sort of burn. So if you think back to the Institute for Healthcare Improvement's triple aim of better outcomes, lower costs, and improved patient experience, and add the fourth aim, which makes it a quadruple aim of improved clinician experience, if an organization can work towards this activity, then in what they do, that's one way to prevent burnout. Tom Bodenheimer at UCSF has talked a lot about moving from the triple aim to the quadruple aim, and it's an important way for an organization to help prevent their providers from burning out. Let's look at the personal side first, and then we'll go to the organizational side. So what can an individual do about burnout and to help prevent burnout? First, they can build resilience. Resilience is the immunization that we give ourselves to help prevent burnout. Where does resilience come from? Well, if you look at the studies, it comes mostly from yourself. Your relationships help, your work helps, your organization helps, but it comes mostly from inside you. This data from the Harvard Business Review is pretty clear that if you're going to build resilience, it has to come from inside you. So what can you do to strengthen resilience? What steps can you take to try to prevent burnout? Well, you can take responsibility for your own training and development. It's pretty clear that if you're learning new things and improving what you do, that helps prevent burnout. You can talk about your feelings and experiences with others. And this is a really important tool. Many of us in healthcare are pretty closed-mouthed when we are talking about our emotions with other people. We just don't do that. We're afraid that it may decrease our appearance in other people's eyes. We're afraid that it might make us more vulnerable. The opposite is really true. If you can talk honestly about your feelings and your experiences with others, especially colleagues and folks at home, you're actually building resilience. You can allow yourself to take real vacations. I think all of us know people at work who never take vacations. They sort of put on their Superman shirt and say, well, I'm working all the time. I have 530 hours of vacation time set aside and I'm saving it. Well, that's not going to help with the building of resilience or the prevention of burnout. So real vacations help, not vacations where you're answering the phone or answering your email all the time. Cultivate meaningful interests outside of work. I talked to a fair number of healthcare providers who are sitting on the edge of retirement, and they are petrified that the only thing they know how to do is healthcare. And they don't really have any interests outside of work. They don't really have any other things that they do. And it's a very risky situation. So cultivating interests outside of work is a way of building resilience, and try to create a work-life balance that works for you. All of us have been in situations where the work side is way too much and the life side is way too little. That may work for a sprint, but it doesn't work for a marathon. So cultivate a balance that's sustainable. These are things that help strengthen resilience. Think about how you think. Try to work to a positive mindset. Instead of saying, I'm not good at this, say to yourself, well, I can learn from a mentor and develop some skills. One of the things that MAVEN does offer is mentorship. And if you're interested in getting a mentor for yourself or for some of your leaders, check in with Jill and with Kristen, and they can help find someone to do this for you. Instead of thinking, this is too hard, think of this as, well, I'm willing to commit time and effort and learn how to do this. Instead of, I made a mistake, I must be a terrible person, think, I can learn from what didn't work. Instead of, I'm getting feedback, which is criticism, think of feedback as a gift that makes you better. Try to go from a negative mindset way of looking at things to a positive mindset way of looking at things. Retrain your brain. Start each day before you get out of bed with spending a minute on, so what's going well? What's one positive thing I accomplished yesterday? What am I doing to make my life better and make the life of my patients better? Some people write what's called a gratitude journal. They'll get a little notebook and write down at the end of a day what went well that day, what you accomplished, and at the beginning of a day what you're thankful for, what things that are present in your life are really meaningful to you. Retrain your brain. Go from negative to positive. Go from cynical to grateful. Assess your current state. There's some diagnostic questions that you can ask yourself, just as you might ask yourself questions about, am I having chest pain? If you're thinking about heart disease, there's some things that you can ask yourself around burnout. How can I take care of myself so that I can continue to be of service to others? How can I strive for excellence and yet give myself room to not be excellent in everything and to make some mistakes occasionally? How can I use my expertise to cure illness at the same time being open to what my patients can teach me? How can I continue to be empathetic and at the same time protect myself? These diagnostic questions are useful in helping to build resilience and leaving yourself open for self-reflection and for alignment of what you're doing with your values. Develop your emotional intelligence. This is the capacity to recognize your own emotions and those of others for motivating yourself while you're managing the emotions in yourself and hopefully in others. You have to understand yourself. You have to manage yourself. You have to understand others and you have to manage relationships. This is probably the heart of the reason why burnout is so hard on an organization when it occurs in the leader. If the leader doesn't understand what's going on in his or her own mind and in his or her own emotional situation, then they're not going to recognize the impact of them on the group that they're leading. So develop emotional intelligence, stay in touch with it, and manage it when you can. Mindfulness is paying attention in a particular way to the present moment, non-judgmentally. And one of the things that a lot of medical schools are working on right now is teaching their students mindfulness. Stop, put yourself on the balcony up above the situation where you're in, and think a little bit about that situation, the present moment, non-judgmentally. This mindful approach to things is often very helpful in terms of building resilience and preventing burnout. Many people find that meditation is a useful tool in building resilience and preventing burnout. There are a lot of different ways to apply it. You can apply it to just living or to health or to other aspects of your life, but spending some time thinking about what's going on is very, very helpful in terms of building resilience and building an immunization against burnout. Thinking about compassion. Many of us went into healthcare to try to help others. We went into healthcare because we cared about other people, because we were compassionate in terms of how we might be helpful to them. And trying to promote the compassion that's already inside you counters the negative psychological effects of cynicism and burnout, and can be a very useful tool to learn some things about in terms of preventing burnout. Think about your home situation. How can you take care of yourself at home? This is as we get into the balance of work versus the rest of your life. How can you make your home situation better? How can you make things more likely at home to help you build resilience? And then we move into the how can you take care of yourself at work? So if you're thinking of ways to do it at home, talking with other people who live with you can be very helpful. Sharing your feelings, sharing your successes, sharing your frustrations can be very helpful. Similarly, at work, those things can help. Jim Rohn wrote this little statement that I think is really a nice way of saying it. The greatest gift you can give to somebody is your own personal development. I used to say, if you'll take care of me, I'll take care of you. Now I say, I'll take care of me for you if you'll take care of you for me. It's a really useful way of thinking about what we do in the healthcare arena. So those were all personal things that you could do on the side of trying to build resilience, trying to prevent burnout. What can your organization do to prevent and treat burnout? Well, organizations can play a big role. And one of the things that we're seeing in many organizations right now is the creation of a provider well-being office or officer to work on organizational initiatives to do this. And let's look at some of the things that are out there that can be helpful. The AMA came out with a list of things that needed to change to decrease physician burnout. I am sure there are similar things coming out of physician assistant organizations and nurse practitioner organizations, but they haven't been as widely publicized. So here are some that came from the AMA. Invest in research. Try to understand in your organization what's causing burnout. Is it administrative inefficiency? Is it problems with your electronic health record? Is it the work setting? What's the problem in your organization? Because if you don't understand what the problem is, it's going to be difficult for the organization to fix it. Try to create positive work environments. Organizations need to redesign work systems to prevent burnout while fostering well-being. This may frequently involve a lot of input from the providers themselves. Try to reduce administrative burdens. Go back to that slide that I showed you early in this talk as to what things cause burnout in organizations, and administrative burden is one of them. In the US, we live in a very highly regulated healthcare environment, and administrative burdens are a real problem for many of our providers. And anything an organization can do to decrease administrative burdens is useful in decreasing provider burnout. Try to create positive learning environments. The fact that your organization in Tennessee is having this talk today is a sign of a positive learning environment. Organizations that offer learning experiences to the providers are very helpful in terms of decreasing or immunizing their providers against burnout. Enable technology solutions. Most of the organizations that we're working with these days are using some form of electronic health record. And many of the companies that produce electronic health records are developing tools to use the technology to make it less burdensome to the people who are using it. A couple of examples, I'm aware right now of a couple of companies that are using artificial intelligence to mock up a clinic interaction note to make it a little faster and a little easier for the provider. Instead of them having to write their own note, they simply have to review one and edit it. There are other organizations that are or other companies that are adding things to help providers remember what they talked with the patient about last time before they have to read the entire note. So technology solutions can be quite useful here. And provide support to your clinicians and to your learners. Try to eliminate the barriers to providers seeking help and trying to do something against their burnout. These things may help an organization help their providers. There are a number of excellent recent articles that have been written on burnout, and I commend them to you. If your organization decides to do some things about burnout, I think it's really worthwhile. You'll note that Tate Shanafelt is one of the authors in a number of these articles, and his work has been just outstanding in terms of helping organizations figure out things that they can do to try to prevent burnout. So go back in a minute, talked about what is burnout. We've talked about what factors you use to diagnose burnout. We've talked about the importance of building resilience as a way of decreasing burnout or immunizing a person against burnout. We've talked about what the individual can do to build resilience, and we've talked about what the organization that employs the individual can do. So those are the things that I wanted to share with you today. They're all important. Burnout is a big deal, and we need to do what we can about it. I'm going to stop there and see if any of you turned in questions to Jill that you'd like me to talk about, or if any of you have comments.
Tom, thank you so much for such an excellent talk. And I don't have any questions right now, but it just posted in the chat. If people want to share, like what works for you individually as a provider, as a person, and what's worked well for your clinic. How has your clinic managed the challenges that they face? So, Tom, if you look in the webinar chat, there's a question, how can we implement change in the system? So we have questions about unionizing, pushing back against insurance companies' overreach, and some great links there. Stop the AMA from blocking mid-level scope of care advancements, and advocating for Medicare for all, physicians for a national health program. And then, so I know there's a lot in there, Laura, that you've included there. Tom, I don't know if you have any.
These are great. These are great comments. How do we implement change in the system? I think, let me comment on that one. You can implement change in the system in your clinic through your state and regional and national organizations. We can implement change in terms of the way clinics interact and the clinics and providers interact with insurance companies, and the way that we interact with government payers from the Medicaid and Medicare side. But change has to take place if we're going to improve. Unionization, I don't know. It may work, it may not. I have a number of colleagues in the National Health Service in the UK who are unionized, and some of whom feel that it has been very helpful, and some who don't. So I don't know for sure whether that's a good solution or not. Pushing back against insurance companies that throw barriers in the way, absolutely. I think that they're trying to make their resources go as far as they can, but sometimes inadvertently they make our lives and the patients we care for much, much more difficult. Uh, Stop the AMA from blocking mid-level scope of care. This is mostly a state level phenomenon. Usually the scope of care and the amount of care that a nurse practitioner or a physician assistant is able to provide is a state level of licensure and a state level of restrictions. So it may be something that you need to work with more at the state level than at the national level. Advocating for Medicare for all, certainly an idea that has been kicked around. If we didn't care for patients who had no way of paying for their care, life would be easier for our patients and would be easier for us. So it clearly makes a difference. And someone asked if I had experience with peer support burnout group. Yes. We had some similar kinds of things in the clinical setting where I worked at the University of Washington, and they can be very, very effective. Many of the residency programs that trained our primary care residents had groups in the organization working between providers and some of the mental health professionals in the organization that helped a lot. A number of good things here. Advice do you give patients who feel that their stories are not being heard? Sometimes the advice is that they need to either work with their provider to pay attention to them or look at a different provider. The patient who's dealing with a very burned out provider who can't or won't hear them probably isn't getting optimal care and may need to work with a different provider who can be a little more responsive to them, while hopefully the person they were initially working with can do some healing on their own. So those are comments with regard to your chats. I really appreciate the opportunity to talk with you today. I commend your organization for having this topic as something that you're listening to, and I bid you farewell. Thank you.
Oh, Tom, there's actually a couple of other of other comments. And I think two people had very similar interests. So one is, do you have any experience with a peer support burnout group, either facilitating or being part of one? And somebody also asked, are you aware of any benefit from, I don't know if it's Ballant or Ballant groups?
So, so that was what I was just commenting on, Jill. I am aware of peer support groups, and we had several of them in the clinics that I was involved with at the University of Washington, and our family medicine residencies. Most of them have Ballant groups named for the work of Michael Ballant in helping people understand the challenges that you face as you begin to try to provide health care, primary care to an individual. It's interesting that the training that is provided for our nurse practitioners and for our physician assistants in some places includes similar groups, in some places doesn't. But they can be very, very helpful at the training level. And then as you move forward into the actual clinical practice and non-training settings, doing a similar kind of peer support group can be extremely helpful in terms of people sharing their feelings and their challenges and their solutions to the problems that are there. Really good question. Thank you.
Great. Thank you so much. So these were some wonderful comments and questions, and I know this is, takes ongoing individual work and also in teams and as part of your organization. So we recognize the challenges that you face and also just have a lot of gratitude for all of the work that all of you clinicians are doing and taking care of your patients and taking care of yourself. So I wanted just to remind you, when you close out of this Zoom call, you'll get a link to completing a CME survey. Please make sure to put in the correct date, which is August 1st, and that Dr. Tom Norris is the speaker. And that slides and the recording will be available to you. The slides will be sent out no later than tomorrow, and the recording will take about a week to come up onto our community portal. Dr. Norris had mentioned that MAVEN Project, in addition to offering medical consults, we also have many physician volunteers who act as mentors, as either a clinical mentor or as a leadership coach. So if you have any interest in exploring that, please go onto the portal and click on mentoring at the top bar, and then you can fill out a brief interest form that tells us a little bit about yourself and what you might be looking for. It's a confidential relationship with our MAVEN mentor. Sometimes people meet about every other week for like maybe about an hour through our video chat on the portal. And you work with your mentor to figure out what your goals are. And, you can talk about if you need clinical skill building to talk about clinical cases, talking about time management, tips for getting through your charting. You might talk about communications. How do you communicate with difficult patients? How do you communicate with your care team? For some people, it might be talking about work-life balance or career development. And if you're a clinic leader, you may be new to the role. It could be something as, how do you set an agenda for your meetings? How do you get buy-in with initiatives from your team? How can you develop your own leadership style? So those are some examples, but we would love to hear from you if you have any interest at all. Wonderful. So everyone, I hope that you have a great day. It was great to see you here today, and we wish you well for the rest of your week.
Thank you.